Good morning, everyone, and today's topic is management of the poison patient and the death from the suicidal is most common reason for the overdose uh, in adults. And today, childhood overdose and deaths are less common because of the protection of the package and education of children and parents. And usually the poisoning is not a fatal because of the medical attention and supportive care. And the primary goal is to manage the respiratory failure, hypertension, seizures, and thermoregulatory disturbances that can result in survival of patients uh, and uh, to uh, to uh, to review the basic principles of poisoning and management of the patient. uh, we will go through the main reasons for the toxicity of the drugs. So, how does the poison patients die? Uh, and Understanding of a mechanism of death due to poisoning help to prepare uh, the treatment of patients. And many toxins depress the central nervous system that results in uh, the coma. And with coma, patients frequently lose their protective behavior and also respiratory drive, and they can die because of the airway obstruction, because of the flaccid tongue, aspiration of gas contents, especially during the vomiting, and also uh, a respiratory arrest. These are the most common deaths due to overdose of narcotics and sedative hypnotic drugs such as barbiturates and alcohol. Cardiovascular toxicity is also frequently encountered in poisoning, and hypertension may be due to depressive of cardiac toxicity or hypovolemia resulting from vomiting, diarrhea, or fluid sequestration. And hypothermia or hyperthermia due to exposure as well as the high temperature dysregulation effects of many drugs can also produce hypotension. Lethal arrhythmias such as ventricular tachycardia and fibrillation can occur with overdose of many cardioactive drugs such as ephedrine, amphetamines, cocaine, uh, and many other drugs. Uh, and uh, Even some drugs like not considered cardioactive, like tricyclic antidepressants, antihistamines, and opioid analogs can result in arrhythmia. Then cellular hypoxia may occur in spite of adequate ventilation and oxygen administration when poisoning is due to cyanide, hydrogen sulfide, carbon monoxide, and other poisons that interfere with the transport or utilization of oxygen. Such patients may not be cyanotic, but cellular hypoxia is evident by the development of tachycardia, hypotension, severe lactic acidosis, and signs of ischemia on the electrocardiogram. Seizures, muscular hyperactivity, and rigidity may result in death. Seizures may cause pulmonary aspiration, hypoxia, and brain damage. Hypothermia may result from sustained muscular hyperactivity and can lead to muscular breakdown and myoglobinuria, renal failure, lactic acidosis, and hyperkalemia. Drugs and poisons that often cause seizures include antidepressants, isoniazid and diphenhydramine, cocaine, and amphetamines. Other organ system damage may occur after poisoning and is sometimes delayed in onset. Uh, Paraquat attack lungs tissue resulting in pulmonary fibrosis beginning several days after ingestion. Massive hepatic necrosis due to poisoning by acetaminophen or certain mushrooms results in certain encephalopathy and death several days later or long after ingestion. Finally, some patients may die before hospitalization because the behavior effects of the ingested drug may result in traumatic injury. Intoxication with alcohol and other sedative hypnotic drugs is a common contributing factor to motor vehicle accidents. Patients under the influence of hallucinogens such as phencyclidine and lyserginic acid, diethylamide, or LSD may suffer trauma when they become combative or fall from a height. So uh, the first uh, the first approach to the poison patient includes the uh, the, uh, the airway. So the to check the airway, should be cleared from vomits and any other obstructions, uh, and patient should be intubated if required. Uh, so breathing should be assessed by observation and pulse oximetry and by measuring arterial blood gases. So patients with respiratory insufficiency should be intubated and mechanically ventilated. The secretion should be assessed by continuous monitoring of pulse rate, blood pressure, urinary output, and elevation of peripheral perfusion. Uh, and then the the physical examination should be done facing those as most likely to give clues to the toxicologic diagnosis. These include vital signs, eyes and mouth, skin, abdomen, and nervous system. So any of these signs are shown here can be the signs of the overdose or toxicity. So the vital signs like blood pressure, pulse, respiration, and temperature are essential in emergencies, and hypertension and tachycardia are typical with amphetamines, cocaine, and antimuscarinic drugs. Hypotension and bradycardia are characteristic features of overdose with calcium channel blockers, beta blockers, clonidine, and sedative hypnotics. Hypotension with tachycardia is common with diacetyl antidepressants, trazodone, quetiapine, vasodilators, and beta agonists. So the eyes are a valuable source of toxicological information. Restriction of the pupils or miosis is typical of opioids, clonidine, unitazines, and cholinesterase inhibitors. Dilation of the pupils is common with amphetamines, cocaine, LSD, and atropine and other anticholinergic drugs. Horizontal nystagmus is characteristic of intoxication with phenytoin, alcohol, barbiturates, and other sedating drugs. The presence of both vertical and horizontal nystagmus is strongly suggestive of phencyclidine poisoning. Ptosis and ophthalmoplegia are characteristic features of botulism. Then the mouth may show signs of burns due to corrosive substances or salt from smoke inhalation. Typical odors of alcohol, hydrocarbon solvents, or ammonia may be noted. Poisoning due to cyanide can be recognized by some examiners as an odor like bitter almonds. The skin often appears flushed, hot, and uh, dry in poisoning with atropine and other antimuscarinics. Excessive sweating occurs with organophosphates, nicotine, and sympathomimetic drugs. Cyanosis may be caused by hypoxemia or by methemoglobinemia. Uh, uh, Icterus may suggest hepatic necrosis due to acetaminophen or mushroom poisoning. Abdomen um, examination may reveal ileus, which is typical of poisoning with antimuscarinic opioid and sedative drugs. Hyperactive bowel syndrome is abdominal cramps and diarrhea are common in poisoning with organophosphates, iron, arsenic, terphthalene, and mushrooms. A nervous system examination is essential. Focal seizures or motor deficits suggest a structural lesion rather than toxic or metabolic encephalopathy. Nystagmus, dysarthria, and ataxia are typical of phenytoin, carbamazepine, alcohol, and other sedative intoxication. Twitching and muscular hyperactivity are common with atropine and other anticholinergic agents, and cocaine and other sympathomimetic drugs. Muscular rigidity can be caused by haloperidol and other antipsychotic agents, and by strychnine or by tetanus. Generalized hypotonicity of muscles and lower extremity clonus are typical of serotonin syndrome. Seizures often caused by overdose with antidepressants, especially cyclic antidepressants and bupropion, uh, cocaine, amphetamines, terpene, isoniazid, and diphenhydramine. Classic coma with absent reflexes and even an isoelectric electroencephalogram may be seen with deep coma due to sedative, hypnotic, or other central nervous system depressant intoxication. It may be mistaken for brain death. So the uh, most common uh, most common toxicity is seen. Uh, so uh, um, the management of the patients with the poison should be done in 5 steps. First step is decontamination and limit the contamination, removing the toxin from the surface of the skin or uh, from the GI with an artificial vomiting. And then second step is recognition of the toxidrome to prepare the care system by vital signs and symptoms. Then third step is introducing antidotes to save preventable deaths, and also extensive decontamination to protect care system that remove the remnants of the toxin. And then to complete the care, patient should be transported to the hospital. The most common intoxication is intoxication with acetaminophen, and acetaminophen uh, is commonly used for suicide attempts and accidental uh, poisonings, both as the sole agent and in combination with other drugs. Acute ingestion of more than 7 grams is considered potentially toxic for adults and even less for children. And a highly toxic metabolite is produced in the liver. So the N-acetylparabenzoquinoline is a very toxic agent that is usually inactivated by glutathione. But during the overdose, uh, the more the normal conjugation uh, way of the metabolism is uh, saturated, and then paracetamol is metabolized to the toxic metabolite N-acetylparabenzoquinoline, that is NAPQ, and then that leads to the acute hepatic necrosis because of the depletion of the glutathione, so that can conjugate with this toxic metabolite. And then initially patients are asymptomatic or has mild gastrointestinal upset like nausea and vomiting, but after 24 hours evidence of liver injury appears with elevated aminotransferase levels and hypoprothrombemia. In severe cases, liver failure occurs, leading to hepatic encephalopathy and death. Renal failure may also occur. The severity of poisoning is estimated from a serum acetaminophen concentration measurement. If the level is greater than 150 or 200 mg per liter, approximately 4 hours after ingestion, the patient is at risk for liver injury. Chronic alcoholics or patients taking drugs that enhance P450 production of toxic metabolites are at risk with low levels. The antidote acetylcysteine acts as a glutathione substitute, binding the toxic metabolite as it is produced. It is most effective when given early and should be started within 10 hours if possible. Liver transplantation may be required for patients with fulminant hepatic failure. Amphetamines and other stimulants are also very common drugs of abuse, and that include methamphetamine or crack, methylene-deoxymethamphetamine or MDMA or ecstasy, and cocaine or crack, as well as pharmaceuticals such as pseudoephedrine and ephedrine that are available in a pharmacy. Unlike the previous substances are mostly sold, so only sold streets illegally, and also some herbal agents like marijuana. So this is Chinese one. Caffeine is often added to dietary supplements sold as metabolic enhancers or fat burners. Uh, Newer synthetic analogs of amphetamines such as 3,4-methylenedioxypyrovalerone and various derivatives of metcamphenyone and are becoming popular drugs of abuse, often sold on streets such as bath salts with names uh, with fancy names. And the doses usually used by stimulant abusers, euphoria and wakefulness are accompanied by a sense of power and well-being. At high doses, restlessness, agitation, and acute uh, psychosis may occur, accompanied by hypertension and tachycardia. Prolonged muscular hyperactivity or seizures may continue to hypothermia and rhabdomyolysis. Body temperatures as high as 42 Celsius by centigrade uh, have been recorded. Hypothermia can cause brain damage, hypotension, coagulopathy, and renal failure. Treatment for stimulant toxicity includes general supportive measures as outlined earlier. There is no specific antidote, and seizures and hypothermia are the most dangerous manifestations and must be treated aggressively. Seizures are usually managed with intravenous benzodiazepines, temperature reduced by removing clothing, spraying with water, and encouraging evaporative cooling with fanning. For very high body temperatures, more than 40-41 degrees by Celsius, neuromuscular paralysis is used to abolish muscle activity quickly. Anticholinergic agents have a large number of prescription and non-prescription drugs, as well as a variety of plants and mushrooms can inhibit the effects of acetylcholine at muscarinic receptors. Some drugs used for other purposes, for example, antihistamines, also have anticholinergic effects in addition to other potentially toxic actions. For example, antihistamines such as diphenhydramine can cause seizures. Tricyclic antidepressants, which have anticholinergic, quinidine-like, and alpha-blocking effects, can cause severe cardiovascular toxicity. The classic anticholinergic uh, syndrome is remembered as a red as a beet, skin flushed, and hot as a hair. Uh, that is hypothermia, dry as a bone, dry mucous membranes, no sweating, and blind as a bat, blurred vision, cyclopedia, and mad as a hatter, confusion, delirium. Patients usually have a sinus tachycardia and the pupils are usually dilated. Agitation, delirium, or coma may be present. Muscle twitching is common, but seizures are unusual unless the patient has ingested an antihistamine or tricyclic antidepressant. Urinary retention is common, especially in older men. Treatment for anticholinergic syndrome is largely supportive. Agitation patients may require sedation with a benzodiazepine or an antipsychotic agent, for example, haloperidol. The specific antidote for peripheral and central anticholinergic syndrome is physostigmine, which has a prompt and dramatic effect and is especially useful for patients who are very agitated. Physostigmine is given in small intravenous doses with careful monitoring because it can cause bradycardia and seizures if given too rapidly. Physostigmine should not be given to a patient with suspected tricyclic antidepressant overdose because it can aggravate cardiac toxicity resulting in heart block and asystole. Catheterization may be needed to prevent excessive distension of the bladder. The antidepressants, especially tricyclic antidepressants, for example, amitriptyline, desipramine, doxepin, are among the most common prescribing drugs involved in life-threatening drug overdose. Ingestion of more than 1 gram of tricyclic antidepressant is considered potentially lethal. Tricyclic antidepressants are competitive antagonists at muscarinic receptors and anticholinergic bindings uh, are common even at moderate doses. Some tricyclics are also strong alpha blockers which can lead to vasodilation. Centrally mediated agitation and seizures may be followed by depression and hypotension. Most important is the fact that tricyclics have quinidine-like cardiac antidepressant effects on the sodium channel that cause slowed conduction with a wide QRS interval and depressed cardiac contractility. This cardiac toxicity may result in serious arrhythmias, including ventricular conduction block and ventricular tachycardia. So these are potentially threatening. Treatment of tricyclic antidepressant overdose includes general supportive care and endotracheal intubation and assisted ventilation may be needed. Intravenous fluids are given for hypotension, and dopamine and norepinephrine is added if necessary. Many toxicologists recommend norepinephrine as the initial drug of choice for tricyclic-induced hypotension. The antidote for quinidine-like cardiac toxicity is sodium bicarbonate. The bolus of 50 to 100 milli equivalent provides a rapid increase in extracellular sodium that helps overcome sodium channel blockade. Don't use physostigmine, although this agent does effectively reverse anticholinergic syndromes. It can aggravate depression of cardiac conduction and cause seizures. Monoamine oxidase inhibitors are like phenelzine, phenylcypromine, and all the antidepressants that are occasionally used for resistant depression can cause severe hypertensive reactions when interacting foods or drugs are taken, and they can interact with the selective serotonin uptake inhibitors. Newer antidepressants like fluoxetine, paroxetine, citalopram, and venlafaxine are mostly selective serotonin reuptake inhibitors and are generally safer than the tricyclic antidepressants and monoamine oxidase inhibitors, although they can cause seizures. Bupropion has caused seizures even in therapeutic doses. Some antidepressants have been associated with QT prolongation and Torsades de Ponte antiarrhythmia. Selective serotonin uptake inhibitors may interact with each other, or especially with monoamine oxidase inhibitors, to cause the serotonin syndrome, characterized by agitation, muscle hyperactivity, and hypothermia. Aspirin poisoning is a much less common cause of childhood poisoning death since the introduction of child-resistant containers and to the reduced use of children's aspirin. mostly replaced by the paracetamol. It still accounts for numerous suicidal and accidental poisonings. Acute ingestion of more than 200 mg per kilogram is likely to produce intoxication. Poisoning can also result from chronic over-medication. This occurs most commonly in elderly patients using salicylates for chronic pain who become confused about their dosing. Poisoning causes coupling of oxidative phosphorylation and disruption of normal cellular metabolism. The first sign of salicylate toxicity is often hyperventilation and respiratory alkalosis due to medullary stimulation. Metabolic acidosis follows, and an increased anion gap results from accumulation of lactate as well as excretion of bicarbonate by the kidney to compensate for respiratory alkalosis. Arterial blood gas testing often reveals a mixed respiratory alkalosis and metabolic acidosis. Body temperature may be elevated owing to uncoupling of oxidative phosphorylation. Severe hypothermia may occur in serious cases. Vomiting and hyperpnoea as well as hyperthermia contribute to fluid loss and dehydration. With very severe poisoning, profound metabolic acidosis, diseases coma, pulmonary edema, and cardiovascular collapse may occur. Absorption of salicylate and signs of toxicity may be delayed after very large overdoses or ingestion of antipsychotic tablets. General supportive care is essential after massive aspirin ingestion, for example more than 100 tablets. Aggressive gut decontamination is advisable, including gastric lavage, repeated doses of activated charcoal, and consideration of whole bowel irrigation. Intravenous fluids are used to replace fluid losses caused by tachypnea, vomiting, and fever. For moderate intoxications, intravenous sodium bicarbonate is given to alkalinize the urine and promote salicylate excretion by trapping the salicylate in its ionized polar form. For severe poisoning, the emergency hemodialysis is performed to remove the salicylate more quickly and restore acid-base balance and fluid status. So, and this is the summary of the vital signs during the poisoning by anticholinergic, cholinergic, opioid, and sympathomimetics, as well as sedatives and hypnotics. So, this vital signs can be used for the quick diagnosis and pre-treatment with the antidote. So thank you very much for your attention, and if you have any questions or comments, feel free to leave them below.